Hello and welcome to Health Professional Radio. I'm your host, Neil Howard. Thank you so much for returning. In this segment, we're going to be speaking with Dr. Mark Varvares. He's joining us here from Mass Eye and Ear to talk about his study on head and neck surgeon perception of oral tongue depth invasion. This information was presented at the 2022 American Academy of Otolaryngology Head and Neck Surgery Foundation annual meeting. Welcome to Health Professional Radio, Dr. Mark Varvares. Thank you for joining us.
Thanks for having me. I really appreciate the opportunity to speak with you this morning.
Give us a bit of your professional background, if you would, and explain to our listeners what your position is at Mass Eye and Ear.
Great. Thanks, Neil. So I'm a head and neck surgeon, which means I'm an ear, nose, and throat doctor who is specialized in the management of head and neck cancer, both the removal of head and neck tumors and the reconstruction of the defects that we create in management of these tumors. I'm currently a professor and chair of Otolaryngology, head and neck surgery at the Massachusetts Eye and Ear Infirmary at Harvard Medical School.
I said that you were going to talk about some information that you presented at this year's annual meeting. What is surgeon perceptions related to oral tongue depth invasion, and what is the importance as it relates to the study?
Yeah, thanks. That's a great question, Neil. So let me start with why is estimation of depth of invasion important. So the depth of invasion really describes how far a tumor penetrates into the tissues surrounding it. And so you might think about how much of what we're seeing is the tip of the iceberg, and where's the total depth of the iceberg. We need to know the total penetration of the tumor into the surrounding soft tissues for a couple of reasons. Before surgery, we like to know what the depth of invasion is because it helps us determine what the risk is to the patient to develop cancer spreading to the surrounding lymph nodes in the neck. Because we know that if the risk of microscopic disease to those lymph nodes is high, that we want to proactively remove those lymph nodes because we have high level of evidence studies that say patients do better if you take out the lymph nodes containing microscopic disease compared to those patients where you wait until there's a lump in the neck and you realize now there's a cancer. So the depth of invasion is probably one of the most important preoperative, pretreatment factors that we have in oral cavity cancer management that drives how we approach management of the patient's neck. So that's why depth of invasion is important before we even get to the operating room. It really helps us plan the procedure in advance to know what issues are we going to need to address. Because skinny tumors, we don't need to remove lymph nodes. Deeper tumors, we need to remove lymph nodes. The other thing that's important about depth of invasion is in the operating room, in the management of the removal of the tumor itself, it's been found to be critically important that we remove the entire tumor. And that may sound really intuitively obvious to most people, but it's actually it's a complicated situation, and we need to make certain that in a three-dimensional way that tumor is completely removed with a margin of normal tissue around it to really be assured that the tumor is completely removed. And you might imagine that if you're going to go and resect a tumor, knowing in advance how deep it penetrates into the tissues so as to guide how far deep into the tissues the resection needs to be done, this could be really, really helpful. So typically, the number of ways that we help determine depth of invasion and penetration into the deep tissues before surgery have traditionally been what does the surgeon think when they examine the patient, and look at the tumor and feel it with their finger. Does it feel thick or thin? And so that's the first pass that we have at determining what the depth of invasion is. Then we have other adjunctive measures. One is imaging. Did the patient have a CT scan or an MRI scan, for instance, to help us determine this? And then there are other methods as well. Did the patient have a biopsy? What kind of biopsy was it? And did the patient have one of these newer approaches, an intraoperative ultrasound, to tell us tell us with some detail what the depth of invasion was for the individual tumor.
Why the study in the first place? Was there some debate as to how important this aspect of surgery was? Was there some debate as to the different methods? Why the study, and what were some of the key takeaways from that study?
Yeah, great question. So the question about why the study is, it sort of backs up to my first point, and that is the depth of invasion is a really critically important factor in the diagnosis and treatment of a patient. In fact, it's so important that the American Joint Committee on Cancer staging manual in its latest edition actually completely redid how we stage oral cavity cancer patients based on depth of invasion, which previously was not even really on the radar of the staging system. So it's a critically important factor. And so what we wanted to do with the study is determine, hey, how good are surgeons estimating the depth of invasion prior to surgical management of their patient? And if they're good at it, great. If they're not good at it, we need to figure out what is the best non-invasive way for us to determine ahead of time what the depth of invasion is. Because when we treat cancer patients, we stage them before we treat them. And if you think about what I just mentioned about how depth of invasion has become a really important factor in how we stage patients before treatment, you can see how important it is to kind of understand what the depth of invasion is before we treat the patient. Because treatment is really designed to be modified based on patient stage. Lower stage tumors, simpler treatment. Higher stage tumors, more complicated treatment. So this is a really important part, as I mentioned, in the diagnostic workup and staging of the head and neck oral cavity cancer patient. And then, as I also mentioned, it has an important role in the intraoperative management. So we wanted to see how good are surgeons at estimating the depth of invasion. If they're good at it, great. If they're not, we need to find some different approach to use.
So what were some of the major takeaways from the study?
The major takeaway is that actually surgeons are pretty good at estimating the depth of invasion. Mm-hmm. And although other approaches may be more sensitive, like intraoperative ultrasound, which has an amazing correlation to what we see histologically, ultimately surgeons are pretty good and do a good job at estimating the depth of invasion before treatment. Do
you think that this aspect needs to be studied further?
No, I think absolutely it does need to be studied in greater detail. This was a relatively small study overall, and so this would need to be, evaluated in a much larger group of patients to see if our pilot studies really hold up when looked at in a more extensive group of patients.
Do you have a time frame for this follow-up study, or is it just in the conceptual works right now?
Yeah, we're just really in the process of putting together a multidisciplinary, multi-institutional study group to answer this and other related questions.
Is there anything that you'd like to add briefly, and then give us a website where our listeners can learn more about Mass Eye and Ear?
What I would say is the awareness of oral cavity cancer is probably one of the most important take-home messages for this audience. And that is, if you see a lesion, an abnormal lesion in the oral cavity, make sure that the patient gets referred on to the appropriate healthcare provider, because early detection in oral cavity cancer, like all other cancers, is really the key to optimal patient outcomes, both from a functional standpoint and from a controlling the cancer standpoint. Our website is www.masseyeandear.org.
Mark, I appreciate your time this morning. Thank you so much.
My great pleasure. Thanks. Have a great day.
You as well. I'm your host, Neil Howard. You've been listening to Health Professional Radio. We've been talking with Dr. Mark Varvares. Audio copies of this program are available at hpr.fm and healthprofessionalradio.com.au. You can also subscribe to the podcast on iTunes, listen in, download at Anchor, Spotify, and be sure to subscribe to our our YouTube channel at youtube.com/Health Professional Radio.